few thoughts in mind. We just want it to be a very interactive sessions. Let's hear from Dr. Rupesh Agrawal on two very important topics. He will be talking to us on AI in ophthalmology, from algorithm to real world scenarios and the products which are there, and also what is the evolving role. So now we have heard the retina practices, we have heard about the IOL power calculations, which is a major chunk, but there is a complete different dimension of AI which Rupesh always brings on up his sleeves. And over to you, Rupesh, for these two exciting talks, and then we request you to stay back for an interactive Q&A session.
Thank you, my dear friend Manoj, and thanks for a very enlightening talk by Dr. Uday and Dr. Sarath. I think we'll move gears towards a couple of things which I am going to highlight. It's not going to be diabetic retinopathy, it's not going to be the macular degeneration, it's not going to be the IOL power. It's all about some of the orphan diseases of ophthalmology, because I did my fellowship in uveitis and ocular trauma. So unfortunately, these two diseases, you don't get that crowdsourcing of the huge database, unfortunately. And these are the two things which I always been passionate about, how you can apply AI into this. So I'm going to divide my talk into a couple of things. One is about the clinical scenarios of the uveitis or the ocular trauma, particularly the case based on the uveitis. And what are the technical components, or what happens inside the black box, some of the terms I'm going to throw at you about the complex terms which is used in the AI world. So two big deals to me, at least based on my fellowship which I started in 2001 in Shankar Netralaya, is on the uveitis with Dr. Biswas and eye trauma with lots of leaders, and we've been working on this for last 20 years plus, and how it has changed my practice and how probably it will change my practice in the coming years is something which we are going to learn from the uveitis. Now, as we know, at least those people who are sitting in the audience, the delegates who are sitting here, the audience, the uveitis is a very heterogeneous disease with multiple different presentations. No two diseases are alike, and everyone present with a different way. Heterogeneity is the key word. But within this heterogeneity, can AI play a role? That's the big question which we are asking. AI research has been shown to be proven very valuable in AMD, diabetic retinopathy, glaucoma, cataract, and multiple other things. But can AI play a role in the disease where it is lesser prevalent and very heterogeneous? All two diseases are different. Now, let's get into the technical components of it, and along with when we are talking about the technical components, so that you should understand when people throw up the different terms like machine learning and NLP and all kind of stuff there, and how do we kind of bridge that with our clinical practice. So the first term which comes to us is every time is the machine learning framework. Now, machine learning is something which we do as a human brain, and we always process the data and all, but instead of we doing it, we let the computer process that millions and tons of data, and then that's where the computer plays a major role, and then that's where the terms like CNNs and all those things are being used. Now, when we apply these machine learning techniques to the data from the registry or from the database of uveitis, this is what we get. Now, this is one of the tool of multiple tools called as GLMnet. Now, what this chart shows, there are certain things on the right side of the chart, certain things on the left side of the chart. What it tells us is which are the factors which will help me tell this patient is going to do good or going to be worse or going to be the predictive factors. So when a patient is sitting with me, based on this calculator, which we are going to convert it into a calculator, I'll be able to counsel a patient in a better way that you are a female of age 40, you from Indian ethnicity, probably you have a better chance of recovery, or you have more 3 times chances of recurrence of the disease based on a patient's demographic, based on clinical presentation. This is where this GLMnet, or this is where a machine learning tool can be translated into clinical practice. Again, the way the data can be visualized is something which I built it up from the ocular trauma, just because the uveitis thing was not fitting in. There were so many variables, but in the ocular trauma, these are the different variables which can affect the outcome. And all these things will go into that model of GLMnet or any of the machine learning techniques which will come up, which will tell you about a particular patient sitting in front of you, about what his final visual acuity is going to be based on these different components. Because one thing you need to remember, when we talk about AMD, diabetic retinopathy, the number of variables they have taken into consideration into building a model, probably 3 or 4 or 5 or maybe 10. But here we are talking about 250 variables. With uveitis, I'm dealing with 3,800 different variables. How do you build a model? because you have to take into consideration every single factor when a patient is sitting in front of you. You can't say, okay, your visual acuity is this, your AC cells is this, your retinal edema is this, and I will tell you. No, you have to take into consideration the patient as a whole. And that is where the AI models need to be refined, need to be defined in as you move forward in the future. Now that's about what machine learning can do. But what is available to all of you right now while you are sitting in this thing about our last 4 years of work is something called a Scott's calculator, and the inspiration was from IOL calculator. I said, if IOL people can design, my colleague has designed EVO formula, Yotun Kwan is my colleague, Dr. Devgan from Singapore, and they can design Barrett formula, they can design, why the uveitis people cannot design a formula. So I got inspired to design a Scott's calculator formula. Now this Scott's cal has been used in multiple clinics across wherever the people practice uveitis, and we key in the few things which is required for a physician to start anti-TB therapy in a patients with suspected ocular TB. So you key in patient's endemicity, you key in patient's type of uveitis, anterior, posterior, intermediate, retinal vasculitis, you key in patient quantiferon gold, you key in patient MEN2 test, you key in patient chest x-ray. Not only that, what we have incorporated in this thing is also if it is not done or the tests are inconclusive. It is not just the binary yes, no, but it is also about if the test is not available in a particular context, like TB quantiferon is not available in everywhere. And then that gives you a predictive outcome about how a patient will do or what a doctor can do to probably decide. Now this is the work which will be featuring at ARVO. So we spoke about the calculator, but the work which is going on, built on this is 700 cases. Now this is only 733 eyes of around 500 cases about the different model. Now before a model is you see, you kind of do this AUC, area under curve, to identify which is the good fit model. Now here you can see a good fit model. We are trying to work on the 7 different model. And from there, we will identify one particular model, which you will see as a final outcome or final thing which will be placed to you. This is all happening inside the kitchen. This is all happening inside the black box, where we will identify a good model, and then we will be able to tell you, this is a good model, which you can use it in your patient with a uveitis, and you can then predict a outcome in terms of recurrence for a patient with uveitis. So that's about the machine learning and the predictive outcome. Another interesting word which comes up again and again is the explainable AI. But explainable AI in the machine learning is something, again, we are trying to do it in the context of Scott's calculator, where we are trying to use this explainable, why such a thing is happening, is something explainable machine learning model. And this is where we are validating this tool for 12 months outcome, wherein we are able to show using XG boost about the 0.92, 92% accuracy about using this calculator, using this SG boost technique. So once again, you can see the application of AI in the context of diseases like ocular tuberculosis, the diseases like uveitis. Now let's shift gears. The another buzzword which we hear again and again is something called as a ChatGPT. So we try to use, when the ChatGPT was rolled out a year, 2 years before, we thought let's use it in uveitis context, because our patients are going to use, whether we are going to use it or not. So we better stay one step ahead of our patient. So what we try to do is we try to put into a model of ChatGPT 3.4, 3.5, 4.0, and the uveitis expert with different years of experience, and trying to compare. Sorry, I've got another.
No,
one.
no, you can go ahead. You can go ahead.
So where we combine these two into and compare whether it can give. I was surprised to see it is almost accurate as 64% as compared to the uveitis expert. I am feeling whether I'm going to lose my job, So that's something which everyone is scared, is are we going to lose the job to AI? But no, probably this can assist you. This can assist you in not making a blunder. So this is something which you should use smartly. But what I'm scared of, if ChatGPT is going to give me 7 diagnoses, and I'm going to give patient 5 diagnoses, and if the patient reads through his ChatGPT 6th and 7th diagnosis, is the patient going to file a medico-legal case against me after 1 year that the Dr. Agrawal has not told me about the 6th and 7th diagnosis of intraocular lymphoma or probably some masquerade syndrome, which ChatGPT has told me on the day 1? I don't know. We have one of the posters at ARVO about medico-legal litigations about related to the ChatGPT. But that's about the ChatGPT. There's something again which we are using is transfer learning, leveraging, and we as uveitis specialists are always a bit poor. We try to learn from medical retina, we'll try to learn from rheumatologist here. Again, here we're trying to learn what people in the medical retina field has done, trying to evolve and then trying to put it into the model of the uveitis. Hopefully, we'll be able to come up with a better model based on this transfer learning, and this is what which is happening right now. We are trying to learn from Dr. Devgan's work about the IOL power formula, and probably we'll try and use some of those things in uveitis as well. But an interesting thing which you will start seeing is something called as a fake currency, which sometimes rolls out, but here in this data world is called as data augmentation or synthetic data, which colleagues of us and we have been working on. So both the numerical data, because when you can't crowdsource, when you can't get millions of data, probably we are trying to mirror image these images. These are the OCT fake images, and we are trying to see whether we can apply the same machine learning techniques to this to understand choroidal structure and some of the retinal structure, and this is where some of the statistics are there, and this is one of the paper published by Professor Ching Yu from Singapore Eye Research Institute group. Now, something which I am personally kind of very passionate about, and again a buzzword in the field of AI, is federated learning. In very simple word, it is called as model to data approach. So I develop a model in Singapore, but I deploy it in Chhattisgarh, I deploy it in Madhya Pradesh, I deploy it in Calcutta. The model is coming to the data rather than the data coming to the model. I think that's where the future is, and this figure can explain to you the model which we are setting up is a global model which can flow into different parts of the world, including the developing countries and the developed countries, and the different way, and that is where the data will be probably analyzed at source. All the AI algorithms will be plugged into that. You don't need to put in the data into the cloud. We don't expect you to put in, and that's where probably the future of when this such a regulatory landscape is there, where we are going to use the federated learning. And last part is something, again, not very completely understandable word is the explainable AI, about why such a predictive algorithm happens. And the first figure I like you to draw attention about the model, data and prediction, explanation, and human makes decision. And this is where AI sit with you in the clinic. So this is a model which is your data, and your predictive tool, this is sitting here, and explainer, which is one of the model is Lime model, and this fits with you, and this allows you to make a informed decision assisted by AI. So when I use my chat GPT in my manuscript writing, I am smart enough. I don't write down as it is copy paste. I try to tweak some words so that it fits into the proper context. And that is where the explainable AI comes into the picture. The last bit is, can you apply into the sciences, biosciences? Yeah, we have been using it in the biomarkers, some of the complex model to understand this biomarker. The reason I put this here is just not about the data, it is also about the biomarker, and last bit is also about the images and some of the things which we have done with only 200 images for choroid, 200 images of the choroid using some of the novel technique called as vision transformer techniques, and this is a fairly accurate model which we have integrated now into the portal which I developed 3 years before called as Coin portal. Now you click on the image, you can get entire structure about the choroid, and this is just based on the 200 images. So we are forcing ourselves to look into the data set with minimum number of images, minimum number of data. So this is the segmentation part of it. But now what we are trying to do is to merge everything, and this is again anterior segment OCT which we have segmented using 500 anterior segment OCT images. Fairly accurate to give you corneal thickness, anterior chamber depth, anterior volume of the anterior chamber, lens thickness, iris vascularity, angles, everything. And haven't patented it yet, but in the process of filing that. So this is all the things which I spoke in last 12 minutes or so. We are going to put everything together into a single portal called as a Proton, which is my uveitis program, and this is where you will be hearing from me in next coming years, called as Program for Ocular Inflammation and Translational Research. But this is built on the data, this is built on the basis of the image segmentation, this is based on the learnings which we had from the clinical experience, and everything put together will be featured in the form of a program called as Proton. Thank you very much for your patient listening.
Thank you, Rupesh, for the ever enlightening talk, and it's always great learning for all of us from every time we listen to you. Now let's start from basics. So we are quite sure that AI is definitely going to be the way forward. Point number one. Definitely, AI has to be incorporated in different specialities of ophthalmic practice, whether it is a patient screening model, whether it is learning model, whether it is predictive models like UVITs or IOL power calculations, retinal practices, and then the referral practice. So definitely is going to be a big boon. Now, suppose if I am a technologically challenged person, Rupesh, yeah, Sharat, you can come. Even Dr. Uday, you can come. We'll start from the basic because we have good 20 minutes out for discussion. So let's start, this is the way we started using AI or started, getting into AI incorporated into our practices. Where do we start as a technologically challenged person who is just looking forward, to different data, to EMR and so on? So where do you see for a general ophthalmologist these practices, fit in?
Manoj, before coming for this talk, I was thinking about it, but I really got a very nice answer from Dr. Uday. I'm going to use it again and again about that 0.5 diopter buffer, which is such a nice thing. He's still using that Barrett formula as his reference, but then using the AI to say that, okay, if it goes 2-3 diopters here and there, then he start doubting whether the AI is off or whether the Barrett formula is off. At least he's got a reference. So if I have to do that, I will start looking into my clinical vision. I made a diagnosis of toxoplasmosis, but this guy is giving me some very funny diagnosis, this AI guy. So if this AI guy is giving me a diagnosis which does not fit to me properly, I will start thinking, oh, something is wrong, something has gone wrong in my model, and then I start questioning the model and all, right? Uday, what do you think in my UVIT if I have to translate that?
Absolutely. The AI is not going to take the place of a physician judgment or surgeon judgment. Yeah. So AI is to augment it, and that's why when you do the calculations, whether it's counterfractive or IOL calculations, we leave a tether or a leash. So that the AI dog can only go as long as the leash you give it.
Yes, I like it, really. Very nice.
Okay, and we also thank both of you to getting these technologies, for wide usage in ophthalmic practices in India. Now, the second question for any general ophthalmologist comes is when I incorporate AI, can I get an assistance to learn AI technology in my practice from any of these peer groups from abroad? Okay.
This is a very interesting question. So, when you use FICO machine, I don't know, means I haven't used it in that sense.
Because we are still learning.
How many of you understand the fluidics of the FICO machine? Do we need to know everything of the fluidics? And here again, which we don't know. We just know this is the pedal, this is the memory, and then keep pressing, and then keep chopping the nucleus, keep taking it out, and all those things. So again, I don't know how much we should know. Even you're driving the Tesla car or something, how much we know about it. Car gets ended and then you call a software engineer or someone like a car mechanic to fix it and all. So here I will suggest, when it comes to the practice, you need to understand some of the basic things about it, just enough. So if AI has to embark on this learning thing, it should be a practical AI which is good for a general practitioner or general ophthalmologist, not to getting into the complicated terms which I was mentioning. But I think it's not important at all. But some simple terminology you should be aware about and you should be familiarize yourself with, but without getting into the too complex Python code and Anaconda and all those stuff, right?
No, I 100% agree. You don't have to understand what XG boost is. I understand. You understand. But you don't have to. It doesn't make a difference.
Yes.
You don't have to know exactly how he said, how does the exact way the peristaltic pump works. You have to know that peristaltic pump is going to require occlusion to have the highest vacuum. So you have to understand the basics. And that'll all come. But the AI is going to be integrated seamlessly. Another way we're doing this, I have another project, a company called Horizon Surgical in Los Angeles. It's fully automated robotic cataract surgery. And we're now developing AI algorithms so we can learn and get better and better every case. This is coming. It's
I was coming on that question, Uday. Now, my next question was this on the future. And I have learned about this platform already from your website that, this is going to be the future of cataract surgery. Again, minus the financial aspect of it, okay? Because, these kind of practices cannot be generalized. It's going to be quite expensive platform. How do you feel on the precision point of view is going to change the ophthalmic practice? Just from the precision point of view and the patient safety and the benefit.
For like robotic cataract surgery?
Yes.
Well, here, I'll give you an example. You watch my videos, YouTube gives them to you at 25 frames a second. You watch Netflix, it's 25 frames a second. So your best visual resolution is 1/25 of a second. If it happens faster than that, you can't even notice it, right? Your Netflix video looks very smooth. Now, I can now have an interop OCT to measure at 10,000 times a second. Or high def cameras also at 10,000 times a second. Your best reaction time is 200 milliseconds, if you're good. F1 race car driver, 120 millisecond reaction time, really good. Our new robotic system reaction time, 1 millisecond. How do you compete? So now when we're operating, you're operating and doing a cataract surgery, the fluidics aren't quite perfect, the posterior capsule comes up a little bit, you hardly notice it until the phaco probe hits it. Well, here, the thing is looking at it 10,000 times a second, and when it senses that the capsule's coming forwards, in 1 millisecond, it can increase the infusion pressure, push the capsule back. So with the stuff that's coming, obviously it's still years away, but I'm telling you it's coming. I'm working with this company. My financial disclosures, I'm heavily invested in it. Very heavily. I'm no dummy. So if you really want to know more about it, it's on literally the Cataract Coach podcast. Not just the video, but the podcast from last week. Podcast number 50 is all about this and what's coming and, basically investing in the future of ophthalmology.
Okay, so the next question will be based for both of you now, Dr. Sharath also. How are you going to take us 10 years from now? What's going to change in ophthalmic practice? Suppose we meet 10 years later in the same meeting now. So what is going to change, and what change we are looking forward for good, and how should we change it? 3 parts of my question. Yeah, let's start with Rupesh.
I don't know what's going to, but anyway, I think to answer Manoj 3 questions, basically yes, AI is going to become an integral part. Those ophthalmologists who have adopted the AI in the practice will survive. Those ophthalmologists who defer, it's like learning the computer, and those who have not learned the computer are finding it difficult nowadays to practice a thing. So it's as simple as that. So it's like computer or mobile phone. Now every single lady, housewife, everyone use the mobile phone, every elderly person. So it's something like that. So every single person will be using the AI.
Because Rupesh, sorry to interrupt you. I heard a quote from a very famous ophthalmologist from Asian subcontinent about few years back.
Yeah.
And he quoted his presentation when he started, like, if I don't change myself to incorporate AI in my practice is never going to change.
Yes.
I got you. I hope you got it. So, change is only constant, as we all learn. That's what we are here brainstorming in this meeting. So, yes, go ahead now.
The only example I will give, parallel example, is those who have visited Singapore, there is a famous shopping center called as Mustafa, those who know that. It did not transform its care during the service delivery model in COVID time. It never went digital. The business went down by 80%. Only 20% business was doing because it never went digital. And we did a digital transformation certificate and all those things. The practices, why Nokia out of the business of Apple and Samsung? Because it never changed. And Nokia therefore is out of the business and all those things. And there are a lot of stories about it. You can read about it. So I think that's number 1 thing. Number 2 things is that at the same time, what we need to be aware is, as we are going to mature ourselves in the AI, our patients are going to be even more mature. So I think that tomorrow they are going to refer to Dr. ChatGPT and Dr. Amazon Q and all kind of stuff which are coming up in the market. More and more of this are coming up. So I think you are going to face a very difficult patient. So you need to be prepared for it, because those patients are going to come with something unexpected question. Second, and then the third bit of it, what Manoj is saying is, the practice will go on, but probably it will be a very, very different looking kind of a thing there. And I think what I envision myself is I'll be doing bit of a hybrid kind of a practice, where bit of a tele, bit of digital, bit of surgery and all those kind of stuff. So I think it is better we start moving it slowly rather than something which is very traditional. Not sure whether I answered all, but I just try to attempt to.
I think you have answered all of this. The last bit, which everyone always is puzzled about, where do you stand medico-legally? Yeah. What's the thought in US as of now on medico-legal aspects of all these practices?
It's always the surgeon's fault. That's the bottom
that's
line.
very true. That's very true. But are there any concerns regarding on the medical legal usage thoughts on this?
See, I have Uday, one or Sarath, we have one question about, or anyone here. Maybe we can get Dr. Divya is there from Remedio, and they've been using quite a lot of AI in fundus camera. So, Dr. Divya, let's say your Remedio fundus camera is not able to pick up AI graded diabetic retinopathy, and I am the user of it. I review your AI report. I say, okay, your report is normal. Tomorrow the patient goes to a doctor, retina doctor, and the doctor says you have a diabetic retinopathy, CSME is there, and you need to undergo urgent injection, otherwise you lose this thing, or some kind of viral retinitis is there and you need that. Now, is that I am at fault, or is Remedio software at fault, or who is at fault, or how do you put that? So Dr. Divya is the medical director of Remedio.
Yeah, I wanted to get her actually, and Divya, to flip this question, you need to answer this question in two parts. Suppose an ophthalmology misses, okay, I'm not blaming anyone, all of us are here, and a AI based platform picks up, and suppose it gets challenged in the court of law. Do we, how do we stand there? So this is also possible.
Can Mike?
You can come forward and talk to us. If can you get a mic, please? For
Mike.
Thanks so much.
Give that mic. Maybe. Take that.
Thanks so much for these questions. I think there's a lot of debate going around about this. I think medical legal challenges, ethical challenges are something that everyone's still talking about. It's still evolving. But then there are two scenarios for AI use as of now. One is where you use it as a clinical assist tool. As Dr. Devgan mentioned, it's going to enhance the clinical decisions made by an ophthalmologist, and the other is an autonomous AI usage, where the decision is completely made by the AI. When it's a clinical assist tool, where the end decision is still being made by an ophthalmologist, the general consensus is that the final decision is still made by an ophthalmologist. It's not dependent on the AI. When you use it as an autonomous use, where there is no specialist there, you have an operator who's just used it, no background in ophthalmology, then I think the general consensus is moving towards taking on the manufacturer who's brought on the AI, and if it does not meet the specifications that are already laid out in the intended, in the IFUs where the performance is laid out, then the manufacturer takes on the liability. So this is the general consensus, but that it's moving towards, but it's evolving. There's no right answer yet. There are a lot of countries which don't have regulatory frameworks. So I think we'll have to wait and watch to see what's going on. But at least in the US, this is how this is sort of moving towards.
Yeah, points well taken. The another two important points, though we have another one more session lined up on tele-ophthalmology or telemedicine practices in the afternoon, but I want to drive two very important points here. One is if you read regulations by Government of India, which includes Niti Aayog as well as people who are on the regulatory body who are driving the consensus of medical legal aspects of telemedicine practice in India. Still there are no clear-cut guidelines. So try to make yourself quite safe even in the outreach programs. And we also need to be very wary of aggregators who are using these platforms in all specialties of medicine and bringing those patients to you for treatment or trying to enroll you for the on those platforms. So try not to get mixed up in all these things, because both are unregulated as of now and legally not safe. Now Rupesh, Dr. Sharad has a question.
Sir, just one question to you regarding that COTS tuberculosis analysis. So the tuberculosis treatment in the endemic area and non-endemic areas is different. So because in India, if you see a slight probable tuberculosis also, we go on, the pulmonologist will say, no, we need to treat that with the ATT part of it. So does it cover even that, or is it based on the specific countryside which is there?
Yeah. So I was trying to see whether there is an internet which is working. Otherwise, I could have shown you the demo. Is that internet is here? No. Okay, never mind. Yeah, it covers. So that's the number one question which we ask. Where is the patient coming from? We know that people will not be so very oriented with the endemicity of this thing. So we just ask them, is the patient from India, China, Singapore, wherever, and automatically it picks up from WHO list of endemicity of that. So that's the first thing which comes up, endemicity, and that's we integrated. Then the second thing it asks is the type of uveitis, and then the 3 clinical tests: chest X-ray or CT scan, Mentu test, because some countries, some sites they do Mentu, and then third is the quantiferon gold. And based on this 3 and clinical phenotype and endemicity, these are the 5 which we take a decision making. Yeah, endemicity is covered. And we also did, but we never incorporated, is the endemicity of a person practicing in which region. But with that one, we did not include it because that also affects the practice pattern.
And the second thing, sir, whenever there is a number of classification increases in the AI, the sensitivity and specificity decreases. So having in retina only 3 to 5 amount is only will take lot of time and lot of data part of it.
Correct.
And when you are including more than 200 when you are saying,
Yes.
so how you feel like in the it's working right now?
Yeah, correct. So that's the real world which we are trying to bring in. I totally agree with you. Our current predictive thing is only 60%, nowhere near there. But we are trying to build upon that because moment you start saying 90% but with lesser data, I am not very confident that you're not taken into HbA1c and multiple other factors when you give a counseling to a patient of diabetic retinopathy, where you taken into only consideration few things. So I always bet, and Adnan and I and Pierskin and I, we always have this lot of debate, and we had a lot of debate going on at data standardization level with Michael Chang and all level, is about how much to put in, and that's a question which has been asked. And more larger the data, then you lose that predictability and sensitivity and all those things. Smaller data, then you gain that. But again, it's the
So coming to Dr. Khatri's question, like in the future, so initially when doing the retina surgeries, for example, for GIT, you have to make the patient bed ulta, then we have to do the surgery and all. And slowly the techniques evolved, the surgeries become easy. In the future, I think AI will help us still more further, and definitely we need to adjust to that, or else it will be difficult further.
Definitely agree with you. We need to evolve with the technology as well. Any questions from the audience, comments, suggestions?
Excellent talks.
Thank you, madam. Thank you. And
anyone not using AI in the practice, not using
So
AI.
if they don't want also, they will be using in one way or the other way.
No, one way or other, yeah. Everyone using looks like, right? Everyone using kind of, someone not using, right?
The mobile also will be using.
Yeah. One way or other, it has been integrated into that thing.
everyone's AI is working on what's served in the lunch area, right?
Everything's going to be seamlessly automated. You won't even know. But I think at the end of the day, everyone's always going to blame the surgeon. Look now, you have in Tesla autopilot. If there's a problem or there's a crash, whose fault is it? The driver. Your radiologist buddies, you get a CT scan and they say, well, here's the this and this diagnosis, but correlate clinically. In other words, your fault. So no matter what, the hand's going to be pointed at you. It's going to be your fault. You're the surgeon. You take all the blame.
You know, we brought up the topic of Tesla. In Singapore, we don't have to. I was driving my Tesla just yesterday. I stepped a little bit ahead on these traffic signal. Then I thought, okay, let me put a reverse. And then I was in the reverse gear. And then the signal light's on. I forget to put it in the forward gear. And it was still in the reverse. I pressed the accelerator. It just went behind. Luckily, I was good enough. Whatever 10,000 seconds you said control, I managed to do that, my infusion pump on, and then suddenly I pressed it in front. But I think the autopilot would have kicked in even much before I would have dashed on the car standing it's parked behind you, you know.
The plane I got on to fly here had autopilot, right?
Yes.
But it still has a pilot too.
So I don't know how many you have written read the disclaimer of our usage of all these technologies. They always mention at the bottom that the consumer is always protected in this. So you better become a consumer rather than a deliver.
That's the same thing they put on the cigarette, is that if you get a lung cancer, you are the person who are going to be the responsible. Everywhere they put in on the cigarette packs those pictures of the lung cancer, and in the end it is injurious for your health. Smoke it with your own caution and all those things, you know. But still we smoke it and we look at the picture and we admire that picture and then we still continue to smoke it, you know. It's like that.
Okay, so
Thank
let's wind up the session, and thank you so very much for all these our international panelist speakers who have come all the way to share their insights, and hopefully we will learn much better on AI based platform in future as well. Thank you Uday, thank you Rupesh, thank you Sharad, and thank you all the audience. Without you this session would not be so fruitful. Thank you AIS as well.
Thank you. Sure, let's do it.